I'm Dr. Bradley Bale, co-founder of the BaleDoneen Method, along with Dr. Amy Doneen, and it's my pleasure to present one of a three-part series about the BaleDoneen Method. What I'm going to present is how we assess an individual patient for cardiovascular risk. I do want to point out that Dr. Doneen and I both have academic appointments. We're both associate clinical professors at Washington State University Medical School. We're also assistant professors at University of Kentucky College of Dentistry, and we're adjunct professors at Texas Tech Health Science Center in the Department of Nursing. What I'm going to present in this short video is an overview of how the BaleDoneen Method will assess somebody's risk from a cardiovascular standpoint. And our method for doing that is anchored in a disease inflammatory platform. And we believe the first thing that patients need to understand is some critical education. We concur with Nelson Mandela that education is the most powerful tool through which to change the world. We would expand that to say education is also the most powerful tool through which we can clobber cardiovascular disease. So we have to establish some basic education with our patients up front that we have called event reality. Patients need to understand that most heart attacks and 85% of strokes are not caused by cholesterol buildup in the wall of the artery that blocks the flow of blood. As a matter of fact, 86% of heart attacks come from cholesterol buildup that is less than 70% obstructing. With that type of disease, a patient can get on a treadmill and pass it all day long. So what does block the flow of blood? Well, we've known that for 32 years. It's a blood clot. Dr. Marcus DeWood published that in New England Journal of Medicine. It's a clot that blocks the flow of blood, not the cholesterol buildup. So let's take a look at an image, autopsy image of a patient who died from a heart attack. What I want you to pay attention to is the lower right part of that artery is where the cholesterol buildup was. The upper left is the huge blood clot that formed that killed the person. And what you can see is the lining that was sitting above that where the cholesterol buildup was broke. And when it broke, the big clot formed, and the clot was so huge that it squeezed back into the space where the cholesterol had been. And we call that surface that sits above that cholesterol buildup the tennis court. You know it as the endothelium, that single layer of cells that lines every vessel that we have in our bodies. Well, we happen to have about 60,000 miles of vessels. So that means when you take those cells out, you could easily cover 5 to 6 tennis courts. And tennis court's an easier concept for our patients to understand, and we let them know it's the most important organ in their body, because heart attacks and strokes still kill and disable more people than any other disease, and they can only occur after the tennis court fails twice. It has to fail 2 times. The first failure is when it allows that cholesterol to seep below it and collect in the wall, but then you have to get the second failure where the tennis court cracks or breaks, and then you get the devastating clot. So we'll look at one other autopsy specimen of somebody who died from a heart attack. In that hole, you can see where the blood was flowing prior to the heart attack was huge. It was wide open. This is an autopsy specimen. So when they made the cut, part of the clot fell out of that hole, but it had totally obstructed the hole and killed him. You can also clearly see where the cholesterol buildup had been below that tennis court, where the tennis court broke in two places. Then the devastating clot occurred. Again, it was so massive, had so much pressure that it squeezed into the spot where the cholesterol buildup has been. So what we're talking about is disease that will collect in the wall of the artery in a silent but potentially deadly manner. So this is a cross-section of an artery. You can clearly see where that little red asterisk is. That's cholesterol buildup in the wall of the artery. And that thin tennis court that's sitting over the top of that could break or crack. And if it does, this patient's going to get a devastating blood clot. So this disease collects silently but potentially deadly in the wall of the artery. You're not going to be sitting around watching TV in the evening and think, oh my gosh, I think cholesterol is collecting in the wall of my artery. You're not going to know that. When Amy and I were in Rome, Italy, presenting data, we were in a plaza where they have the square gutters, pigeons are all over the place. We're kind of having fun for a little while watching the scene, and then all of a sudden it gets kind of frightening because we start noticing, well, golly, cats will slither into that gutter. They'll get just low enough where the poor pigeons can't see them. The pigeon gets close enough to the edge of that gutter, out leaps the cat, and they've got a meal. So we looked at each other and said, you know, that's really like arterial disease. It gets in there silently, but is potentially deadly. So we nickname disease in the wall of the artery, cholesterol plaque, the cat in the gutter. And it's a concept our patients can understand very easily. And then in 2012, others started saying a similar message. Look, disease in the wall of the artery, quote, a cat in the gutter, is essential to have a heart attack. It's a condition sine qua non. Therefore, evaluating for a cat in the gutter should be fundamental in risk assessment. So we were very happy to see that published in American Heart Association Journal 6 years ago, because that's exactly what our method had already been doing for about 15 years. Since then, numerous publications have also come along to state virtually the same thing. This publication came out in 2015 and basically stated most initial heart attacks are occurring in people that are not considered high risk. Therefore, our current method of assessing somebody for risk, which is based on simply looking at risk factors, needs enhancement. They went on to point out that detecting subclinical, asymptomatic cats in the gutter in the heart or the carotid arteries will identify individuals who are at risk for a heart attack or stroke, and that should certainly impact their management. So we were very pleased to see that in 2015, and then it's just continued. These are publications in the Journal of American College of Cardiology. This one came out stating that the presence of subclinical disease in the carotid and the femoral significantly are associated with increased risk of heart attacks and strokes. And they can be used to reclassify a person's cardiovascular risk. They went on to say evidence is now clear that it's non-obstructing arterial disease that's responsible for the majority of events. And they pointed out millions of Americans are at risk basically for heart attacks and strokes, and they're not being identified. And the reason they're not being identified is because the standard is still waiting for that symptomatic obstructing disease, and the fact is most events occur from non-obstructing disease. So that gets us to this excellent cartoon of the BaleDoneen method. Our method from the get-go has been on a platform of evaluating each individual patient for cats in the gutter. And that platform is held up by an extremely powerful arch, which on one side is anchored in the education we talked about. Then we look for disease. Then we recognize it's fire or inflammation that causes that disease. And we look at root causes of the fire. Then we optimize the management of all those potential sources of inflammation of the artery. And we anchor all of that work in precision healthcare by doing genetics on that individual patient, so we can get more at the core of their uniqueness and not have to treat them as the average of a huge study population. So the keystone of this arch is inflammation. The platform is looking for disease. So the BaleDoneen method does an assessment for cardiovascular risk based on a disease inflammation platform. It's extremely powerful. So how can we go find these cats before they start causing symptoms or cause a heart attack or stroke? We've got that technology, and we've had it for some time. Dr. Doneen and I published in this Journal of Clinical and Experimental Cardiology 4 years ago a paper which was extremely exciting, stating that we now live in an era where we can guarantee arterial wellness. And that guarantee is based on two evolutions in healthcare. One is we now have the technology to go find disease in the wall of the artery long before a patient would know it's there. The other element we'll get to in a little bit, so just hold on. So what technologies do we have to find these cats that are asymptomatic? One that we started using about 25 years ago was looking to see if there's calcification in the coronary arteries. The first technique that would do that was electron beam tomography. That company eventually got bought out, and now they use rapid CT to detect calcium in the coronary arteries. If you see calcium in a coronary artery, there's no question. I don't care if the score is 1 or if the score is 2,000. That patient has disease in the coronary arteries. You've identified somebody who's had the first failure. And if they have that second failure, which is driven by inflammation, they're in trouble. So certainly calcification of arteries is a way to find out if you have disease. And we have lots of other images that can show that. One example, this was given to us by one of our dental colleagues, a panoramic view of the teeth. You can clearly see calcification in the carotid artery. This patient has cats in the gutter in the carotid artery. They are at risk for a stroke, and there are publications, of course, that back that up. Another way, just as an example, is on a mammogram. If there's calcification in a mammary artery, that female is at risk for heart attack and stroke. So with calcification of arteries, we can certainly find these asymptomatic cats as subclinical disease. Another way we can find these cats is with ultrasound of the arteries. And in the year 2000, the American Heart Association actually came out with their expert panel on prevention, stating that carotid IMT testing is safe, reliable, inexpensive, and valid. So Dr. Doneen and I started doing this type of testing 18 years ago. And we've written papers on it for healthcare providers, explaining to them how this is such a marvelous clinical tool for finding subclinical disease, identifying that patient who may appear healthy, who actually has risk for a heart attack or stroke. It's also known that femoral plaque, if you have cats in the gutter in the femoral arteries, you're at increased risk, of course, for heart attacks. And the femoral arteries can be looked at with ultrasound too. So we do that on patients. If we don't find it in the carotid, we'll go look at the femoral arteries. Femoral plaque is very common. It's a great place to look. But some of our colleagues missed a very important paper that was published in 2001. It was a study, Cafe to Caves, and it was published in 2001. It was a 10-year study. So they started recruiting patients for this study in about 1980. So let's take a look at this study, because some colleagues will make statements like, well, what are you and Dr. Doneen doing? Everybody gets cats in the gutter. That's silly. Why even look? Or they'll make a statement like, well, so what? You found a cat in the gutter. The patient's healthy. What are you doing treating them? Well, this study gives answers to both of those questions. It was a study where they looked at 10,000 healthy people ranging in age from 35 to 65 years of age. Every patient that got in this study, they looked for disease in the carotid artery with ultrasound. They looked for disease in the femoral arteries with ultrasound. The caveat to get in this study, and the reason this study can never be repeated, is the following. No matter what was found, the patient could not receive any treatment for 10 years or until they had a heart attack or stroke. And then there's a check mark, of course, in the study. They can go do whatever they want. Well, you couldn't run a study like this now. Of course, we know we have treatments that can help prevent heart attacks and strokes. In 1980, we didn't know that. So they could get this study approved. So let's take a look at the results. There were 4 findings with the arteries. One, the artery's perfectly normal. You don't have any cats in the gutter. There's no signal that a cat is gonna form, like that layer where the cholesterol collects. It's no thicker than it should be. How many people have perfectly normal arteries? Almost 80% of them. You just told me everybody gets cats in the gutter. Well, it looks like they don't. The second finding was there's still no cat in the gutter, but there's a signal you may develop one. That layer that builds up cholesterol is a little thicker than it should be, but still doesn't qualify for a cat in the gutter. If you add that in there, you're getting close to 90% of people did not have cats in the gutter. The third finding was, yeah, you got a cat in the gutter there, big deal, the hole's still wide open. The fourth finding was, you don't have a cat in the gutter, you got a tiger in there. That thing's so big when the blood tries to go by it, it disturbs the blood flow. So let's see what happened to these individuals over a 10-year span of time. If you go to your right, the ones that had tigers in the gutter, over 80% of them had a heart attack or stroke within 10 years. If you go with the ones that just had a cat in the gutter, it's not blocking the flow of blood, the hole's still wide open. 40% of those people had a heart attack or stroke. High risk is considered a 20% 10-year risk. This is 40%. The ones that didn't have a cat, apparently some of them went on and formed a cat, because 8 to 9% had an event during the 10 years. And if you go with the ones that had normal arteries, virtually nobody had a heart attack or stroke. So this study clearly illustrates a couple of important points. everybody doesn't get cats in the gutter. As my partner, Dr. BaleDoneen, loves to state, arterial disease is getting more common, but it's not a normal stage of aging. And certainly, if you find a cat in the gutter, you'd have to be a pretty brave gambler to say, well, there's a 60% chance I won't have a heart attack or stroke in the next 10 years, so don't bother treating me. I think most people would want to be treated, especially when you consider the standard of care, 20% is high risk. So an excellent study that a lot of people aren't aware of, and it can't be repeated. So because we evaluate every patient for disease, which is sine qua non for an event, you have to have disease, you have to have a cat in the gutter to have an event, we've redefined prevention. Primary prevention for us is we've done due diligence. We can't find a cat in the gutter. That patient has extremely low risk for an event. If they really don't have a cat in the gutter, it's not going to happen. That's primary prevention. The goal of therapy would be, we're going to work on you so you never do get disease in your arteries. Secondary prevention is, yeah, we found a cat in the gutter. It's never bothered you. It's never jumped out, caused any problems. We're going to make sure it never does. That's secondary prevention. Tertiary prevention are those patients where we knew when they came in they had cats in the gutter because those cats had already bitten them. They'd had a heart attack. They'd had a stroke. They had to have bypass. They had to have a stent. And the charge of our therapy at that point is, we're never going to let that cat jump again. So this redefinition of prevention will also clarify a lot of confusion with the research on, well, is aspirin good for primary prevention or not? If you look at the study a certain way, yes, it is. Another way, it isn't. Those studies, they had no clue which patients had cats in the gutter. If you don't have a cat in the gutter, why are you taking aspirin? It's probably going to cause more harm than good. If you got a cat in there, I think you better be on aspirin in case that thing jumps. You're not going to get as big a clot. So we can go find these cats. But if we were missing this next element with our knowledge, who'd want to go find cats? Probably nobody, if you didn't know what to do about it. So now you can not sleep for the next 20 years because we know you got a cat in the gutter, a thing could jump on you any minute. Well, that's not the case. We have knowledge of what causes the cats, what causes arterial disease. And that was in that paper that we published 4 years ago. What causes arterial disease? It's the keystone of our arch. It's inflammation. That was first proposed 162 years ago by Dr. Virchow in Germany. And we've based our method on that for over 20 years. We felt the evidence was solid enough, conclusive enough to do that. Some of our colleagues are just now catching on and believing that yes, indeed, inflammation is the cause of arterial disease. Look at the date on this. This just occurred in August of 2017. That's very recent. Dr. Nissen, one of the world experts in cardiovascular disease, made the following statement after this study called CANTOS was published. In this study, they used a medication that only reduced inflammation in the body. It didn't do anything to the cholesterol. And they showed that medication significantly reduced the risk of heart attack and stroke. So after that was published, Dr. Nissen stated the following: for the first time, we have this new target, inflammation. It is sort of drawing a new era. I really think it's big. We're just wondering where he was the last 25 years. We've been saying that for 25 years, but we are happy that even experts like Nissen are now on board. And a month after he said that, in the American Heart Association journal Circulation, this study was published. The end of a controversy. There is no controversy about this anymore, folks. Inflammation is the cause of arterial disease, period. So this is another one of our cartoons. So for us to guarantee that somebody's not going to have a heart attack or stroke, our charge is really pretty simple. All we have to do is keep the arteries cold. If we keep the arteries cold, the patient's not going to have a heart attack or stroke. If those arteries are hot, their body may get real cold. So if that's our charge, that's what we have to do. We obviously have to have excellent, simple, inexpensive biomarkers we can rely on that will tell us if the artery's on fire or not. The great news is we have those. We have 2 urine tests. One, F2 isoprostane, tells us how rusty you are, how oxidized you are. Oxidation creates inflammation. Also says how fast you're aging. Another urine test is simply looking to see how much of that huge protein albumin is seeping through the tennis court and the capillaries of the kidney to show up in the urine. If your tennis court's tight and it's healthy, albumin should struggle to get through into the urine. So when we're seeing a lot of that, we know the tennis court, the most important organ in your body, it's failing, and that's dangerous. Then we have blood tests that look at the tennis court, CRP and fibrinogen. Then we have a blood test, lipoprotein-associated phospholipase A2, nicknamed Plaque 2, which tells us if it's hot where the cats live in the wall of the artery. And if it's elevated, it implies not only is it hot where the cat is, but that cat's probably growing. And then we have another blood test we call the wild card, the joker, myeloperoxidase. Because it's well known if this is elevated, all bets are off. It doesn't matter how great everything else is, how great your blood pressure is, how great your cholesterol is, etc. When this is elevated, you could have a heart attack or stroke if you have a cat in the gutter any second. When we see this elevated, we want an ambulance outside that patient's residence with the engine running and a sober driver in the driver's seat. That's how important that test is. So we have biomarkers to tell us. So our job is simply being firefighters. So if you want to sum up what Dr. Doneen and I do in a real simple way, we look for cats in the gutter and we put out fires. It's as simple as that. But you might be saying, well, how in the world can you put out a fire? Well, you better know what's causing the fire. Because if you don't know what's causing the fire, your management's probably not going to work. It's like if you walk in the kitchen, you see a fire and it's actually being caused by oil, and you throw water on it, goodbye house. So you have to know the root cause of the fire, apply the proper remedy. That's the way of the wise. And that takes a very holistic approach. This is one of our best cartoons by far. The trunk of the tree is inflammation. It's what causes arterial disease, causes those cats to jump out, the clot to form, the heart attacks, the strokes. There are numerous things that can fire up the artery. And all of these have excellent peer-reviewed publications showing how they drive inflammation of the artery. So let's quickly just go through them. Obstructive sleep apnea, really any type of sleep disturbance. The inherited cholesterol problem, lipoprotein A. Low vitamin D will inflame the arteries. higher blood pressure actually causes inflammation of the arteries. Of course, cholesterol can inflame the arteries. Genetics. We do genetic testing, and there are certain genes that will lead to greater inflammation. Periodontal disease definitely can cause inflammation of the arteries. And Dr. Doneen and I just last year published a paper in Postgraduate Medicine showing that the high-risk periodontal pathogens actually are causal of arterial disease. So if you haven't seen that paper, I'd recommend you get it. Insulin resistance, the pre-diabetic condition, fires up the arteries. Dysfunctional HDL, endodontic disease, dental caries, periapical abscesses. One paper implies it may be responsible for almost the majority of acute coronary syndromes. Inflammatory diseases like lupus erythematosus, rheumatoid arthritis, psoriasis, asthma, etc. Infectious diseases like the flu, like pneumonia, definitely can trigger events. Psychosocial issues are huge. Anxiety, depression. That myeloperoxidase, the wild card, is so bad we put it down as its own separate root. Obviously, nicotine exposure. And then gut dysbiosis, which is a field that's just exploding now.